Involuntary loss of urine from the bladder is referred to as urinary incontinence. Urine loss is often unpredictable and places the client at risk for poor hygiene and social embarrassment. Most urinary incontinence develops secondary to abnormal bladder or urethral function. Normally, the bladder is relaxed to allow for accumulation of urine in quantities of 400 to 500 milliliters. When the bladder reaches its capacity, the person senses bladder distension and voluntarily initiates voiding. Parasympathetic fibers then stimulate the bladder to contract and the urinary sphincter to relax. The voiding process is completely voluntary and can be interrupted at any time. Loss of the voluntary component of the voiding process results in incontinence. What are the four major types of urinary incontinence? Stress incontinence develops secondary to weak pelvic muscles or failure of the urethra to close efficiently. Urge incontinence develops secondary to hyperactivity of a network of smooth muscle fibers called bladder detrusor muscle. Overflow incontinence develops secondary to retention and overdistension of the bladder. Functional incontinence develops secondary to a lack of ability, that is, the client can't get to the bathroom or can't sense that the bladder is full. The involuntary loss of urine is always a sign of urinary incontinence, but other clinical manifestations can direct you to the type of incontinence. With stress incontinence, the client is usually female, and urine loss is usually 50 milliliters or less, and it is associated with sneezing, coughing, or laughing. With urge incontinence, urine loss can be from a few drops to the entire bladder contents. The client may feel urgency when hearing running water or when there is a sudden change in temperature or position. This disorder is common among elderly clients, as well as with UTI and neurologic disorders. With overflow incontinence, there is a constant dribbling of urine. This disorder is common with diabetic neuropathy and following stroke, spinal cord injury, and pelvic surgery. Functional incontinence usually follows client immobility, confusion, dementia, and sedation. Management of urinary incontinence is based on the etiology of the incontinence. Medications can be used to treat urge and stress incontinence, but the presence of an obstruction in the urinary tract must be ruled out before any therapy is initiated. Clients who have urge incontinence are treated with over-the-counter antihistamines. Side effects of these medications are anticholinergic, and they suppress the sense of urgency for voiding. Antispasmodic anticholinergics, such as oxybutynin, trade name Dimetrepan or Dimetrepan XL, increase bladder capacity and decrease the frequency of voiding. Over-the-counter sinus and cold formulas that contain pseudoephedrine are also useful for treating stress incontinence. Pseudoephedrine stimulates alpha receptors located in the kidney, causing sphincter contraction. The goal of client education is to provide information about dietary, lifestyle, and behavior changes that will help reduce the frequency and severity of incontinent episodes. Teach clients to schedule fluid intake, strive for a fluid intake of 3 liters per day unless contraindicated, plan for most of the daily fluids to be consumed long before bedtime, and minimize fluid consumption after the last meal before bedtime. Try bladder training with timed voiding, practice Kegel exercises, avoid caffeine, alcohol, and chocolate, and try to keep the skin clean and dry.